All right, I would like to introduce Dr. Kadar Lubin. Dr. Lubin is a professor in the Department of Psychiatry at Yale University in Connecticut. First of all, I would like to start by telling you that our center, the Post-Traumatic Stress Center, is a specialty center. Our expertise are in trauma-related presentations. It can be manifested as anxiety disorders like PTSD, post-traumatic stress disorder, or panic disorder, but it can be depression, it can be personality disorder, eating disorder, and other kind of disturbances. Most of the people who come to us after they failed treatment elsewhere, and they want to get more specialized treatment. All of our staff, therefore, is trained to do what I'm about to review with you. So no matter who you see in our center, if you come to us, you're going to have what we call a trauma-centered psychotherapy. If it's individual therapy, couple therapy, family therapy, or group therapy, it will be a trauma-centered psychotherapy. I, as David said, give medications because I'm a psychiatrist, but even giving medications is done in the thinking about trauma-centered principles. So the medication that I will choose will be taking in account the fact that that person's symptoms are related to their trauma. All right, so let me share with you a little bit about the way we understand and inform our psychotherapy. We will start with what we call the 4 axioms of trauma-centered psychotherapy. Those axioms are reflecting some natures or characteristics of the trauma. The first one is that trauma schemas arise in order to reduce fear, and I'll explain. And as a result of the heightened fear, their perception of what just had happened is going to be informed by the trauma. They develop, therefore, trauma schemas in order to manage their fear. The fear is so overwhelming and frightening that they will do anything to try to avoid re-experiencing it. And they apply that everywhere, so much so that they cannot anymore tell when something is dangerous and something that is not dangerous. Those trauma schemas come to play more significantly when they interact with people in their life and also with the therapist. Therefore, we tell our therapists always to watch for the fear because we know that's where the trauma schema will be expressed. We know that those who've been traumatized will do anything to avoid anything that remind them of what had happened. So they become very avoidant. So when they come to treatment, we should expect them to want to avoid talking about the trauma. But we know that also therapists want to avoid dealing with the trauma because it's very frightening and very upsetting. So the second axiom is that both the client and the therapist will avoid or will participate in avoidance in some time during the therapy, if not many times during the therapy. And what are the common ways of avoiding? It can be shown by delay, that the therapist will not ask about the trauma early on because they don't want to frighten or re-traumatize the client. Or they will try to focus on things that what we call the here and now. People come and they have a complaint. I had a fight with my wife, I have difficulty with my teenage daughter, or focusing on some crisis in their life, whatever it is. We believe that all of those strategies are strategies of avoidance, and they need to be addressed, but from the trauma perspective. So the third axiom of trauma is the narrative. The traumatic story is always incomplete. You never hear the entire story. We know and believe that the distress that the client experiences as a result of undisclosed material from the trauma, or even events that didn't happen in the trauma, but they were worried it's about to happen. So if the therapist anticipates that the narrative is incomplete and the distress is as a result of material that hasn't been disclosed, the therapist is more likely to continue to probe and get the story, more details about the trauma. Many therapists who are not trained in this way of thinking, they ask maybe about the trauma, they hear the story, and they put an end to it, not knowing that indeed there are many more details. Can be attributed distress that actually asking them about the trauma is what distressing them, rather than stopping talking about the trauma is what distressing them, because they are undisclosed material. Okay. The fourth axiom of trauma is the trauma schema, the representational structure that we talked after the trauma. They usually manifested when they are interpersonally related to the person, most likely those who are closest in their life, like family members. In fact, when somebody is more caring to them, that can be more destabilizing to them because they don't know what to anticipate. Opposed of being all the time on guard because you expect you're going to be harmed. So it is not uncommon for, say, women who have been abused as children to be in an abusive relationship as adult, because then it's more familiar and they can keep their guard up. Because of this axiom, it is important as you do the trauma inquiry to also listen to those interpersonal elements that the person reports in their relationship with their loved ones and with their bosses or other people. So those are the four axioms that we like share with you, that reflect on the nature of the trauma. The first thing that is useful in order to get the client to be on your team in the work on the trauma is to review the rationale why you want to do the trauma work. You want to explain to them why do you think it is important to deal with the trauma and how it continues to interrupt and interfere in their life. We know that exposure, imaginal exposure, going back in your mind or by talking to the therapist about the trauma is a effective method of reducing the fear and the anxiety associated with remembering. There are empirical studies that show it, and also in our clinical work, we see it every day. So after you discuss it with the client, say it will be useful for us to work together and to focus on the trauma, you have to get a very thorough trauma history. That needs to happen in the first contact because that is the main aspect of their psychology. We know that traumatized individuals either think about it all the time or avoid it all the time. Either one, that's what they're thinking about. So addressing it in the first contact communicates to them that you really know what you're doing. We also said that in our center, we definitely do it to great details, that the environment of the office has to communicate that we understand how trauma affects people. We have artwork, we have citations, we have representation of things that are aesthetically or affectively communicate what trauma does to the person. So when you go to get, say, a relaxing massage, you want it to be a very pleasant, calm, beautifully set music to calm you before the massage. That will be a different setting than the hard rock kind of buffet, right? So when people come to the office, they get a sense we know what we're going to do here. That is very reassuring for most clients. All right, so now we can talk about the principles that guide the therapist in conducting trauma-centered psychotherapy. There are three principles that I will share with you. The first one is immediacy. What it means is that when somebody comes to our center, we immediately, without any delay, address the trauma in the first meeting. So we come, we say hello, we have them sit, and the next question, we never met them before. Even if it's a new, particularly a new client, we ask them what happened to them. Many therapists are used to spend time to build what they call alliance with the client, and it takes time. They also want to convey that the environment is going to be safe for them to talk about the trauma. We believe that the alliance and a better sense of safety will come as a result of talking about the trauma. And any delay in inquiry and addressing the trauma is going to heighten the anticipatory anxiety for the client if they will stay. So the principle of immediacy asks for that immediate inquiry about the traumatic event and ask of the therapist to do it in a very optimistic and dispassionate way. They need to be direct, not to be afraid to ask a lot of questions about it. If the client appeared to be distressed as you inquiring about the trauma, it is most likely that you missed something. So we tell our staff to go where the fear and the anxiety is and inquire immediately about the trauma. So the therapist communicates to the client that they as well understand the proximity and the enormity of the traumatic effect on themselves. See, the second one is engagement. What we mean by that is that the therapist absolutely needs to be engaged with the client in delving into the traumatic material. And there are different levels to do that. The first one is the nonverbal gaze, how you look at the client. So engagement with the material communicates them that you are trying to be with them as they remembering what had happened. And you cannot be passive, you need to be active, animated, and there is a sense like a real person sitting with them. The other level of engagement is what we see in posture. So, for instance, if they start talking to you about this horrible rape or horrible violence, and you're sitting on the chair and you're doing this, right? What does that communicate? Exactly. It communicates to them that you don't want to hear it and you're getting away from the material. So they will stop, I guarantee you. And the questions that you will ask to elicit those details should be covering all of the senses: smell, or auditory, taste, all of the senses. The more that you can elicit questions like that, the better will be your understanding of how the traumatic experience affected that individual. The fourth level of engagement is the response of the therapist, the affective response of the therapist. So how do you, as a therapist, respond when you hear those horrible, horrible events that occur to your client? We say that you got to be a human. So if something is horrible and you feel, oh my God, that is so horrible, you can say that to the client, say, oh my God, that is horrible. It communicates to the client that what they experience is within the human range of experience that is overwhelming, not only to them, but also to the listener. But the therapist should not communicate that they're afraid to listen to this material. Many times new therapists feel that they need to have this blank look as they're hearing these horrible, horrible events. That is usually experienced by the client as a disengagement, and therefore more likely for them not to continue to disclose. It is what we call emotionality. You should anticipate that if you work with traumatized individuals, that there will be high emotions. Trauma is extremely distressing. You're going to teach them how to tolerate that kind of surge when it is only remembered. So that means that you, as a therapist, need to communicate to them that you can tolerate that level of emotionality. So if your client, as they describe their trauma, crying very loudly or get extremely upset, that's okay. You're not disturbing them. What disturbs them is the perpetrator. So those are the three principles that we usually inform our therapists: the immediacy, engagement, and emotionality. And I would like now to review with you four main techniques that therapists can use in order to follow those principles. The first one, of course, is getting the details of the trauma. So you want a very detailed information about their traumatic history. You want to know, as you recall, we talked about trauma schema being relational. You want to know about any kind of current behaviors that may be informed by the trauma schemas. And you always want to be alert to how they flow between you and the client and habits, but there will be disruption in the relationship as well. We view those kind of disruptions in the therapeutic relationship as a window, a door opening to go even deeper in details to what had happened in the trauma. So as you get the details about the trauma, you want to constantly observe when there is a spike of anxiety or fear, because that tells you that something was missed. All right, the second technique is what we call decoding. Decoding or decrypting means to identify the overlap of the past trauma material with the present behavior. The past intrudes on the moment through the trauma schemas, the way they interact with you. The more that you know about the trauma schemas, the more likely you will be able to decode when it plays out in your relationship or in a group setting or in the family. The client is not aware of the fact that they are doing it. So even just increasing their awareness by highlighting it can be an intervention on its own right. However, trauma schemas are very rigid, and they're more likely to require further techniques. And I'm going to review the next one, which is introducing discrepancy. The discrepancy is an opportunity to highlight the difference between the present and the past. So, for instance, if the client experienced you as the unsupportive or abusive mother, important to highlight the discrepancy because you are not their mother and you're not going to be them. By doing so, you can show them the difference. You know, there was some similarity that caused it, but the difference is that in the present, your therapist is not going to harm you. In the past, your mother did. The discrepancy also gives you an opportunity to help them correct the distorted cognition. In that example, the distorted cognition is that any female authority is going to be abusive, like my mother. The correction will be is that some female authority figures are not abusive, most are not, your mother was. And the fourth main technique that we use in the work, in the trauma center work, is disclosing the perpetrator. There is a huge collusion both in society and also specifically with the traumatized individuals to get their perpetrator free. And the reason is very simple because the perpetrator is very powerful and frightening. As a result, over years, the perpetration itself becomes a representation of the traumatized individual. So instead of saying the perpetrator did something bad to me, they say I am bad. Instead of saying that my harassing boss is incompetent, they say I am incompetent. So you exonerate the perpetrator and takes the blame and the burden of the perpetration onto yourself as the traumatized individual. So it is very important in the work itself not to forget to bring up and disclose from its cover the perpetrator. We ask our clients to name the perpetrator, and when they talk about, instead of saying he raped me, to mention the name of the person who raped you. Also to describe in details who the perpetrator is, how they look, the smell, their behavior, all the things that make them a person in the scenario.